Hi, everyone. Welcome to our webinar on Trending Beyond COVID-19 Special Edition on the OSHA Emergency Temporary Standard. For those of you who join us regularly, you know our cadence is typically once a month, the first Wednesday of the month. But this is such an important topic. We scheduled a special session for today, so I'm glad you found your way to us. We use the same link as we normally do, so we were hoping everyone would be able to figure out how to access us today. And so welcome to our session. As you know, we always record it and upload it on our YouTube channel, so you'll be able to find it on WorkCare YouTube later today or tomorrow. And we will also be using the Q&A function in Zoom for all of your questions today. You can use chat, but we prefer that you use Q&A. It's a little bit easier for us to monitor, so we make sure we don't miss anything. In the interest of time, I want to turn it over right away to our speaker. We'll be taking the full hour. And if you have questions that don't get answered, we'll answer them in writing at the conclusion of the webinar and post those on our website. So our speaker is Anthony Harris, MD, MPH, MBA. Dr. Harris is board certified in occupational medicine. He's our Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's been monitoring trends in COVID since day one. It's been almost 2 years, can you believe it? We rely on him heavily for his clinical insights, as well as his savvy about practical approaches to preventing and managing COVID in the workplace. So thanks again for joining us. And here's Dr. Harris.
Excellent. Thank you, Karen. And thanks to each and every one of you for joining. We already have over 100 of you that have joined us today on this special session. We're deeply grateful for the opportunity to talk about this ETS and break it down here in terms of what is our thought process around protecting the workforce. Let's dig into the ETS a bit. We're not going to go over the high level stuff that frankly you can read for yourselves in the summary that OSHA has put out, right? My gestalt is that many of you have already read and began to digest the ETS. So we're going to go layers deeper in how we should be thinking about this ETS in terms of what's to come, right? How long is this ETS going to be with us? How long should we prepare in our plans right now for this to be a part of our new normal? Hopefully not in perpetuity, but let's talk about it in terms of the foresight that may bring about that inevitability, right? And we're going to be a little nuanced in our approach in terms of thoughts around, as we've been talking about the cost of COVID, we're going to break down some of the numbers in regards to why this is upon us likely to begin with anyway, right? And so without further ado, I want to point out that this is the traditional model, right, for our presentations that you all are familiar with. We ain't going to be doing this today, okay? This is a special session, so we're going to jump right into the nitty-gritty of why we're here today, and obviously that being what is now published back on November 5th in the Federal Register, which made the official start date for compliance in regards to the chain of events that need to happen for each and every employer with more than 100 employees. Now, we last week talked about and answered many questions around the basics, right? You have 100 employees, they're dispersed throughout the US, and they're not all in one place. Are you still under the auspices of this regulation? The answer to that is yes, no matter where your folks are located. Now, with that being said, this is a little off script from what you see in front of you in terms of what we talk about today, but just to make sure everyone's clear, there are criteria for employers that exempt you from this regulation, meaning that if your employees do not report to work, they are remote 100% of the time, then they are exempt. If your employees work outdoors 100% of the time, they are exempt, right? So we know there are several exemptions to this rule. that you need to be cognizant of. But by far and away, we know many employers are under the auspices of this rule. And that's why we're doing this today, to one, go into it a little more deeply and to answer your questions around some of the details of it. So the first thing we want to talk about is the significant risk, right? This is kind of the framework for the ETS, right? Why is it with us to begin with? How did this come about from a legal authority? And it's all hinges on this definition of what a significant risk versus a imminent, or the language specifically around the ETS is grave risk, right? And so, or grave danger. Particularly. So let's break down the significant risk portion of this, right? So the rule says that, and this is getting already into, is this rule going to be with us for some time to come, right? We know that the ETS by the black and white will be with us for 6 months. But as you know, the feds have already said they're going to look for this to become a potential final rule, right, in the register. And that final rule may extend beyond 6 months' time. And that's something that's going to obviously affect us from a workforce management standpoint, obviously financial standpoint. And it all hinges again on the differences between grave danger and significant risk. Grave danger is what enabled the administration to implement this ETS to begin with, right? That's part of the criteria. Lower risk than that is significant risk. So in 6 months' time, a determination will be made likely of, are we currently in a significant risk scenario, or are we still in a grave danger scenario, right? And if we are still at a significant risk, we then know the feds will likely make this and extend this rule so that we are subject to the guidelines for much longer than this 6 month period. Okay, and there's already hints of that, right, from federal communications. So at the end of the day, it really is a determination of what is the actual workplace risk for transmission for our population, right? And let's dig into that more fully here as we proceed through the presentation. So grave danger breakdown, right, is something that the ETS has gone into detail about. You can read it, but we're going to summarize it here in terms of what we want to point out, okay? And if we point out the numbers, then that will help us understand how the feds are thinking about the definition of grave danger, right? And right off the bat, right, I'm going to tell you, I have not found, and I'd love to hear from you all, if you found any good sources for actual objective data of workplace transmissions in the US. As we know, and we talked about over a year ago, the workplace transmission definition is one of a employer-defined event, right? And so we saw early on and throughout all last year, the positive cases that were being caught through screening and testing were then, many of them determined to be not work-related, right? Now, we know that there were outbreaks, and if we look at data from Canada, we can see that there are clear, in the US, there's clear articulation of workplace outbreaks. Aside from those outbreaks, what is likely the incidence and risk for workplace transmission? So as we dig into that, right, we want to truly understand how the feds are thinking about this grave danger versus significant risk. So here's the objective of the ETS, right? If you distill it all down to simple numbers, and then again, this is Dr. Harris distilling it down to simple numbers, the ETS and the feds estimate the ETS will save over 6,500 worker lives, right? There's the grave danger. Prevent over 250,000 hospitalizations over the course of the next 6 months, right? So those are their estimates in regards to prevention of loss of life and health implications, health impacts to the workforce, right? And so as we look forward to the future, right, we got to understand where we're at from a risk standpoint 6 months from now. And if it's lower, we still may be over the threshold of a substantial risk, which will allow the feds to extend this further than 6 months, right? And what would that look like? Would that look like mask mandates? Would that look like social distancing mandates, et cetera? Those are all considerations as you are progressing through your program implementation now to be compliant with the ETS. Okay, and so if we start to look at and break down some application of numbers to this 250,000 individuals that are, hopefully will be prevented from hospitalization, the 6,500 workers' lives prevented. Let's look at now some averages around hospitalization numbers. Okay, and hospitalization numbers, you've seen this in the headlines most likely. One hospitalization costs 150 times more than a vaccination, right, in terms of on average. And so it begs the question, is this the ultimate goal of the feds, to save money? I don't doubt that this is a considerable part of the rationale behind implementing this, but let's see if that holds mustard in terms of true savings for the economy, true savings for our employers. And again, I'm not trying to put dollar signs to the loss of life, right, to the value of life for our workforce. I'm just trying to think and process this the same as you are from a practical standpoint of impact to the businesses, impact to the workforce, and ultimately the sustainability of an ETS that lasts longer than 6 months. So as we break down then the numbers on average hospitalizations, we talked about this briefly in previous lectures. We looked at the average cost. And if we look at the average cost publicly available now from multiple sources, it's around $20,000, right? We know pre-existing conditions like diabetes can push up a COVID hospitalization all the way to $70,000 plus. But on average, with all things being equal, no pre-existing conditions, companies are spending, if you're self-insured, $20,000 per hospitalization for COVID. So now let's do the simple math, right? We're putting on our arithmetic hats here, and we're all learning to do this simple math to show that if we're talking about 2,500,000 workers at $20,000 per hospitalization, that's $5 billion in savings that the ETS will produce if the feds are right in their estimations, right? And so as we think about then, all right, if the feds and the ETS are offsetting $5 billion in hospitalizations in the economy, are we going to outstrip that from the burden that you all are underneath? We all are underneath, including work care, right? We have 700 employees, I think, roughly now. So we're all figuring out here how we're going to be impacted financially in aggregate. So let's break that down. The ETS in some publications, in this case, this is the American Action Forum, and they're a nonprofit organization. They estimated that the ETS will cost for employers with 100 employees or more, $3 billion over the next 6-month period. All right, so okay, we're starting to see some clear sky here in that if we're saving $5 billion, there's $3 billion in cost to employers. We'll save $2 billion net, right? In monetary value, obviously 6,500,000 lives and $250,000 in hospitalization does not account for the lost productivity, the opportunity costs, right, to businesses. These are all direct costs. So we see clearly that the ETS will, if again, these estimates are on point, will net us a benefit as a society. Now, stop before you say, hey, doc, you're just trying to spin the numbers so that you can support vaccinations, et cetera. No, not necessarily, right? I'm just telling you the numbers from a dollars and cents standpoint and from, this is our MBA hat, right? From a practicality standpoint. Does this hold mustard to move forward and support the ETS in your workplace from a preventative standpoint? We've all heard and we preach, right? An ounce of prevention is worth a pound of cure, right? This is that at a macroscopic level, and that's where we're kind of testing the system to see if that holds up. So let's keep going. And we're going to save time at the end of this for questions, because I know you have them in terms of specifics around the ETS, and we can answer those for you. But let's keep going here. So the degree of exposure is what we're after. Is there actual workplace transmission risk? And is it objectively measured in the US? my estimation, my answer is no, right? The best I've seen in terms of trying to understand, are our workers truly at risk for workplace transmission, are approximations from exposures for other communicable illness such as the flu, right? So if we're looking at data from that in studies, as an example for this study that was published February of 2021, trying to get at what is the underlying risk for workplace transmission and how to prevent it for COVID, the degree of exposure we know varies per occupation, right? And they're estimating approximately 10% of workers face exposure for COVID infection once a week, right? Approximately 18.4% face such exposures once per month, all right? So again, on average, we're trying to prevent 18% of our population from a once a month exposure in the workplace to COVID-19. Let's go further. Transmission in terms of approximating the actual transmission risk for COVID-19 follows the pattern potentially of influenza. So as many as 20 to 25% of weekly contacts are made in the workplace. We've talked ad nauseum about what the measure of risk is for transmission, that R naught number, the reproductive rate of COVID. At this point, it being high as 11 people affected by one individual. Remember, the highest number that we've seen from an epidemic standpoint is measles, right? At plus 18 of a R naught. But again, if we look at some of the models for influenza, 9 to 33% of transmissions that occur in the workplace in aggregate, right? And so if we model the risk for COVID after influenza, then we can start to glean the risk for our workforce in terms of transmission that we're trying to prevent. I've still not, and if you have found objective data that has tracked workplace transmissions at a level of fidelity, please share that with us in the comments, and we're happy to discuss that at a future webinar here. So let's revisit what we talked about last week. Now that we're kind of talking about the numbers, we kind of see the incidents that we're trying to prevent in terms of workplace transmission, and we know the cost in aggregate, direct cost in aggregate for such exposure and risk. Let's go back to our approach that we talked about last week, and we'll go a little bit more into talking about the difference in the approaches based upon incidents, right? And so this is the strategy for determining your investment and for compliance versus doing more than the bare minimum, so to speak. And if we looked at that again, look at this chart again, the compliance, right? The bare minimum in terms of investment in a low incidence local community setting, right, will have a sharper curve in terms of enterprise risk and additional benefit if you're going above and beyond what compliance mandates to generate return on investment, right? And so in other words, you can put more resources into prevention and not necessarily prevent more transmissions from happening in the workplace because you're already in a low incidence environment from a community standpoint. And that's going to impact, obviously, your business bottom line from that level of investment above and beyond the compliance to provide not as great of a return on investment in regards to preventing workplace transmission, right? And so in that regard, we want to look at the contrary, which is a high incidence in your local community. There, going above and beyond the minimum to do compliance, right, is going to net you more ROI for the cost that you expend because your enterprise risk is greater. Now, there's a couple factors that go into that enterprise risk. Obviously, it's not just the direct cost for the workforce in terms of prevention. It is truly the productivity of the workers that you're trying to protect. Are they generating a high dollar amount in terms of hour of work to a dollar of productivity? And so looking at that equation, determining that, and it may be different for different worker populations. Obviously, it's going to be different for different locations in which you are operating. And those are some of that's the level of granularity I want you to take and approach when we're talking about putting in place a system for your workforce. Again, if you have 100,000 workers in the workforce, applying a one-size-fits-all could be more costly for you if you're doing that across the board for every geographic. I get it. It might be less of a headache from a straightforward standpoint, but we want to talk about how do you maximize your return on investment, not just in a compliance fashion, but going above and beyond compliance to truly protect your workforce. That's the additional protection zone that we're talking about, okay? And so what are the costs that we want you to keep in mind in the forefront? The vaccine costs, that should be considered. Testing costs. At this point in time, we're seeing a wide range of costs for the test, from $10 to $150. If we're talking rapid antigen tests versus PCR tests, the gold standard still for determining someone's positivity or negativity for COVID-19 infection, right? Savings on COVID treatment. Obviously, we just talked about that, $20,000 for a hospitalization, and particularly the indirect costs, right? Direct costs and indirect costs, the vaccine payroll deduction incentive. So we know that the ETS is mandating 4 hours paid time off on top of existing PTO to get your vaccine, for your workers to get their vaccine, and then paid time off for any side effects in terms of a 2-day period after they've been vaccinated. Now, the approach there to consider is, do you give that additional time off to all your work, to your entire workforce, or just the unvaccinated? That poses a conundrum, right? Because those who have gone already to get vaccinated on their own personal time will not benefit from the additional paid time off that the people who have been reluctant to get vaccinated may be crossing the threshold to do now, right? So again, definitely may be a dramatic increase in cost. If you're deciding that, to be fair, we have to give that to all employees, something to consider in your cost analysis. And then the administrative cost to administer your own program in terms of operations is key to determining, do you outsource this, do you insource this, right? And I'm glad you asked that question around, hey, what are other employers doing? Are they outsourcing? Are they insourcing? Are they trying to take this on themselves? Because we're going to spin this around and start asking you questions here in a live poll. So I want you to break out your phones. We have 160 of you on the line right now. So I want you to pull out your smartphones, or go to your, if you have on your computer, open up another window. We want you to go to slido.com. And we want you to put in this number here, 826402. All right, come on, I'm going to urge you to do it. We want maximum participation here because we're going to ask you some key questions, and we want to see your response here live on this webinar, so that you can glean from your colleagues here how things are going in regards to what their strategy is and will be moving forward. So I'm going to slide over my shared screen here. I'll give you time to go to this website, put in the number here, and we're going to continue with the presentation. Excellent. All right. Okay, hopefully all of you have gone to it. You've put in that number. I'm going to pull over the poll here. Hopefully you all can see that. Perfect, perfect. All right, so the number one question here: what strategy will you use for managing ETS compliance? You should see that on your smartphones here now. It's outsourced, internally integrated, internal standalone, outsource, or internally integrated. Okay. All right, good. We're seeing some good responses here. We have 45, 56 of you, 72 responses. Awesome. We got phenomenal participation and engagement. All right, we got to figure out how to get this engagement on our wellness programs in the workforce here. This is phenomenal. More than 60% engagement here. Excellent. We'll talk about that. We've talked about that, safety to wellness, our engagement platform for wellness. So that's another day for another lecture. All right, perfect. We'll stop there. 95% of you responded. The majority of you are internally integrating your operations not the majority, excuse me, 46% of you, doing it with a standalone internal structure, 30%, and outsource right at 23%. Perfect. Let's go to the next question here. Have you already made a financial determination on your ETS compliance plan, meaning that you've signed agreements with third parties, you've hired necessary internal staff, or dedicated roles already for internal individuals? And Karen, I just want to be sure that everybody's seeing this on their screen. So just confirm for me that everyone can see this.
I'm seeing it fine, and it's really great. I'm participating in the poll on behalf of WorkCare.
Awesome, awesome. All right, 92 responses, and obviously overwhelmingly, the majority of you have not yet made your final determinations. And that is what we're seeing anecdotally amongst all of our employers that we service at WorkCare. That obviously there's things that have happened that we'll talk about in a second here in the marketplace that companies are waiting to see how it shakes out, and they're still yet making the determinations. Now, we know the deadlines are still there, right? And we'll speak to those in a bit, but let's get to the next question. Last question here: what approach most closely reflects your organization's strategy? Enough to be compliant is just fine. Beyond compliance to protect at-risk workforce is ideal. Or let's maximize opportunities to prevent COVID and other potential infectious transmissions, such as the flu, cold, etc. And there's no judgment in these statements, right? We've seen across the board approaches. And again, depending on your risk level at the community level, any one of these may be appropriate and best course of action for your organization. So, muy excelente. We're approaching that 90 response rate, and we're kind of neck and neck with enough to be compliant is fine, and beyond compliance to protect the at-risk is ideal. And again, anecdotally, that's what we're seeing, a kind of a bifurcation of there are a number of employers that are just looking to be compliant, and that's perfectly okay. And a good chunk, about more than a third, in this case, 40% of you are looking to go above compliance, but maybe not investing all out permanent things that will be in place in perpetuity in terms of workplace transmission. Perfect. Thank you for participating with that. Excellent responses here, and that gives you insights to what your colleagues are doing. We're going to switch it back over here to the PowerPoint and keep rolling here. So with that being said, right, we want to answer some other questions here before we get to questions for everyone. In right, in local governments under this ETS, there's been some interesting information out there. I won't call it misinformation, but the answer to that is yes, right? In 26 states, Puerto Rico and US Virgin Islands, public schools are subject to the OSHA, federal OSHA standards, in that they have state-approved OSHAs, right? And those state-approved OSHAs, as you know, have to meet criteria for being at least as effective as the federal OSHA standard in enforcement, right? And also must apply to local government employers, must apply to also public school districts. So we know this is going to play out not just in our private company corporate world, our public corporate world, but we're also talking about our communities, community workers, those who are subject to their state OSHAs. Now, we've seen also the feds revoke a number of states state OSHAs, and that may happen again, right? But as far as we know, if you have a state OSHA, you will have school districts and local governments subject to the ETS. So there are a lot of happenings that are occurring that now throw our estimation of when this and how this will take effect into place, right? And yes, I'm talking about what happened this past Saturday, where we had a federal court essentially put a halt to the administration's to ETS, right? This happened in Louisiana, I believe, and so now we know that it's at the level to which there may be an overturn, right? And I doubt that will be the case. No one is estimating that this will actually move forward in terms of overturning or overruling, overriding the ETS. Anecdotally, most of our employers, as you all have seen, are still preparing their plans to be in place because of this, what we know to be true, that this court order did not delay the date for or postpone the date for compliance, right? The dates for compliance. We know 30 days from publication in the register, Federal Register, is the deadline for compliance with the mandates, the vaccine mandates, right? Getting folks vaccinated. And then 60 days from that in January, early January, is when the deadline is for compliance with testing, optional testing, right? And so those deadlines are still in play, and compliance is not something that is obviously, non-compliance is not something that the feds are taking lightly. $13,000 plus is the per instance penalty. We've all seen those numbers. So these are all the things we want you to consider as you're building your program right now. Is it a program that's sustainable? If this ETS becomes something longer than 6 months time, what is the ultimate impact to your, not just your workforce, obviously, but your impact to your operations, the people that are internally tasked with performing these compliance steps? Is that sustainable? And how will that ultimately impact the longevity and success of your organization? So with that being said, we're going to hit the pause button, and we're going to start taking questions, because we know there are many of you who have some particular questions. We can talk about states like Florida that have an emergency session for the legislature to make it illegal for businesses to implement mandates. We don't know the outcome of that, obviously, but let's answer questions at this point in time. Thank you so much for attending and participating. We'll get into the questions right now.
Okay, thanks, Dr. Harris. And for those of you who are joining late, this is Karen O'Hara. I'm the Director of Marketing and Communications, and I'll be taking your questions through the Q&A function. We got one through chat, which we'll also ask that it's easier to monitor if you could submit them using that function in Zoom, please. Let's get started. Would Dr. Harris agree or not with my current hunch that we'll need to manage through COVID-19 for at least another 2 to 3 years?
I would certainly agree with that. And here's why. If we look at what's to come, I am ardent. I will bet everything but the kitchen sink, maybe even that, that the CDC will, in the near future, once boosters are open to the general public and approved for, will change the definition of what it means to be fully vaccinated, right? And so to that point, this is why you have to consider that inevitability in the program you're building now. So it's not going to be a one and done. We capture everyone who's vaccinated, we hold their records, and we won't have to revisit. Yes, you will, because there will be people that will get boosters. And once the CDC changes their definition, which is what Israel has done, let's be clear, we followed Israel's play, lock and step, is just how things are played out. Then you'll need to re-up on your efforts to document who's gotten their booster, who's not compliant. And the wrinkle is we're seeing already the general population who have been vaccinated, fully vaccinated, a significant number of them, up to a third, saying, I'm done. I don't want a booster. I've gotten my initial 2 shots. And so dealing with that will be something that carries well into 2022 and likely well into 2023 and beyond, right? And the other point and the other trend, as we talk about trending beyond COVID, right? The other trend you have to follow are the drug makers. They are usually pretty darn good prognosticators of where the market is heading. And so if we look at what has happened just in this past week, we saw Pfizer come out with their pill that is it's a drug that's akin to what we do for HIV treatment, an antiviral, and it has been shown to cut hospitalizations by almost 90%, 89%, right? The subset of individuals, 775 of them that were in the study, the experimental arm that received treatment, there were no deaths within the time period of the study. And that was about 36 days, I believe, after receiving treatment. Whereas there were a number of deaths, I believe 7 deaths in the placebo group. So we know that Pfizer is expecting to ramp up productions throughout entire 2022, right? They're only making about 115,000 doses, which is a 5-day course before the end of this year. And so they're expecting COVID to be around for all of next year, for likely 2023 and beyond. So Merck, same thing. Molnupiravir has been petitioned to FDA for approval. They're ramping up 10 million doses before the end of this year and plan to go a lot further, giving the US only, I believe, 4 million doses throughout next year. So again, if the pharmaceuticals are helpful in helping us estimate where the market is heading, they're anticipating things will be around for many, many more years to come. Well, I won't say many more years, but at least 2 to 5 years to come.
Okay, this next one's interesting question about the long view. Since this is trending beyond COVID-19, it fits right in with our theme. Do you anticipate COVID risk will always fall under OSHA and therefore employer responsibility? Or might COVID transition to that of other healthcare issues, for example, the flu? So employers are not responsible for transmission as a workplace illness. I've not heard any talk of this in mainstream media, but it seems eventually it should be treated no differently than the flu in terms of employer responsibility.
Sure. So this is almost, I kind of digest this as almost a philosophical question, right? Who ultimately is responsible for the health and wellness of approximately, I believe the number is 168 million Americans, right? Who all are employed and have some type of employee based insurance, health insurance, right? And so if we attempt to answer that question, from my perspective, I do not see COVID moving away from some level of workplace responsibility. The reason being that if COVID remains as much of a threat to health and wellness, meaning that Pfizer and Moderna's pill for preventing severity and deaths is not long served, then the risk of workplace transmission leading to poor outcomes may still be a mainstream occurrence, right? So in that scenario, it would still be on the responsibility of the employer to prevent what we all saw early on in the pandemic, these tremendous workplace blossoms of COVID, where 60% of the population got COVID, right? Now, if COVID does become endemic and does become more like the flu, where you get COVID, not a big deal, you're sick for a couple of days and you're back to work, then it may shift from employers, but the philosophical approach then becomes how do we as EHS professionals and our role contribute to the productivity and boosting the bottom line of our employers, of our organizations, right? And that, not to jump into the safety to wellness movement that we're starting, but that begs the question, should we play a role? Not must we play a role, but should we play a role in helping our organizations keep the workforce healthy? I think it's a straightforward answer for any self-insured employer, because you ultimately bear the financial risk for whatever health calamity may exist in your workforce. But it's something that where 98% of the SMB market may not have a self-insured employer, and there may be still opportunities yet for our employers to impact the health and wellness of the populace in our communities. So I'll leave it to that level in terms of answering that question. But I do think for the next 2 years, at least 24 months, it will remain solidly the responsibility of employers.
Yeah, that was a really good question. Thanks for asking it. Next question. Does the 100+ employee total include businesses that are franchised? For example, one location may have just 20 employees, but the same franchise may have many more across a state.
Sure. So the franchise question has come up before, and if it comes down to how individuals are, to what organization are the individuals considered employees, right? So for example, corporate McDonald's, let's say corporate McDonald's theoretically has only 50 employees, right? And or we'll put it the other way. Let's say corporate McDonald's has 2,000 employees, right? Is it only the 2,000 employees of corporate McDonald's that needs to be cognizant of the regulatory demand on them versus the franchisee owner who only owns 2 stores and only has, 50 employees, right? So the answer to that is if the franchise owner, and this is what I've gleaned from my study of the ETS, if the franchise owner operates and has a payroll separate from corporate, then those individuals are considered under their own going concern, meaning that each franchise is its own entity in the eyes of the state, right? Pays separate taxes from corporate McDonald's, and therefore, in perpetuity, has its own going concern. From a tax standpoint, it's considered an individual with 2 stores. And that would set forth the requirement for whether or not the ETS applies to that franchisee. Now, let's say that franchisee has 10 stores and then crosses the threshold of 100 workers, then they would be subject to the ETS. Now, I'm not a lawyer. I tried to go to law school. My wife said no. But that is my thoughts in terms of my understanding of corporate structure and how the ETS applies and I apply it through a tax lens to understand whether or not an entity is liable to the ETS.
I guess your wife thought you had enough initials after your name for now anyway.
Oh, it's going to happen, just not in the next year or two.
Oh, great. Okay. Talk more about that later. Okay, next question. Got some really good questions today. I'm enjoying this. The ETS requires employers to ensure that each employee who is not fully vaccinated is tested for COVID at least weekly. Has there been any interpretation on or guidance on how this is managed? Can the employee perform a self-test at home and just verbally state their test was negative? Do they have to do the self-test on site and it be verified by someone at the facility?
Sure. So what we've seen thus far in the ETS is that if an individual is testing on their own with a rapid antigen test, it must be observed, meaning that someone must observe that it is the individual who is taking that particular test. Whether that plays into PCR tests, self-administered, is yet the question that we're trying to get to the bottom of. So I won't give you a final answer on whether a PCR self-administered test must be observed, but we clearly see that the rapid antigen tests need to have a level of verification by a pair of eyes that an individual is in fact administering the individual that's responsible for testing, meaning they're subject to the ETS as an employee, is the one in fact producing the results for that particular assay. We have employers to that point that are electing to solve that problem both on site with a person verifying for administration of the test, as well as home tests under direct observation through remote technology, right? In the same way we do a telemedicine consult, we have employers and we have systems, WorkCare does actively do this, have systems in place to remotely monitor and verify the individual testing is in fact the employee and not their, golden retriever or their 5-year-old kid.
Okay, so Tad is asking a very similar question and he's referring to it as proctoring. So you just answered the question, but I'm going to ask his question because it's a slightly different perspective. Can you please talk about proctoring? We have secured kits, he means testing kits, but the proctoring is unexpected. OSHA gives us very little guidance on what proctoring must look like. You said just now it has to be viewed. I mean, he wants to know, could we just review a picture of people's negative tests or must they be observed?
Sure, I can answer that because I as well don't have a incredible clear interpretation beyond what you've articulated because it is vague. I can speak to though how most employers I've worked with thus far are interpreting that, and it is interpreted by the majority as a pair of eyeballs looking at the process of sample collection and verifying the collection process and result in totality, not only the result itself, because of the issue of falsified tests, meaning that instead of swabbing myself, I only swabbed the tomato in the refrigerator and stuck it in the rapid antigen test. So they are many, I won't say many, but there are a number of vendors that are ramping up the ability to do remote monitor testing for that very reason in terms of how that rule has been interpreted regarding proctoring.
Okay, someone just pointed out that it kind of depends on the level of risk an employer might be willing to assume and to the extent they go to validate the test. So for one employer, a picture may suffice, but another may want to actually have eyeballs on the test. So I guess that's still something that needs to kind of play out. That's what it sounds like.
Indeed. And there's kind of two levels to it, right? One, did you actually take a test? Yes or no, right? And verify that, yes, we see a test, we see that it's negative, and we document that, right? The second layer to that is, did Johnny test, or did Johnny, do some other means to get the result that he snapped a photo of? The other issue is this, right? And again, this is why I believe most employers are leaning towards direct observation for the entire collection and results process. Johnny goes to Walgreens, buys a test, swabs his nose, takes a picture of the results, and keeps the results. And the next week takes the picture and sends it in. And then the next week takes the picture of the same test and sends it in. There is no date other than what may be in the metadata of the digital photo that an individual may upload to verify that it is a new test with a new result, right? So again, it begs the question, going back to my, this is kind of the genesis for this slide, right? Whether you want to do compliance, take the risk, enterprise risk, that, right? If OSHA comes down and says you're non-compliant, right? That's enterprise risk. And going and interpreting the level of compliance to at one level, right? Which may be snap a photo, and it's risky that they take the same photo of the same test for months to go, versus doing the live observation. I believe that's an individual, obviously, to the point of the attendee here that just commented. It is an individual determination for your organization, what level of risk you're willing to take at the enterprise level for your population and for your organization.
Okay, next question. I suspect WorkCare has helped companies determine work-relatedness of COVID cases. What percentage of cases reviewed were determined to actually be work-related?
So surprisingly, we haven't had a huge number of cases to review because it has been something viewed as not a clinical determination, to my own chagrin, perhaps, right? I've presented the criteria upon which you can use to make a determination of work-related or not. But we have not been anecdotally relied on, or historically rather relied on, to make that determination. Rather is made at the level of the HR supervisors, et cetera, in the workplace. So, but again, if we look at the data from that we collect broadly, we still don't see a huge number of work-related cases being reported from an OSHA reportability standpoint, right? Again, would we expect that to be the case? No, right? We know that by far and away, the highest risk for transmission is in the household. So the vast majority of cases, over 85% of cases, happen because of household transmissions, not because of workplace transmissions. And that too may be why we haven't seen a significant number of cases come through for determination of work-relatedness by our clinicians.
Okay, thank you. Next question. How will this be enforced for businesses? Will any business be able to opt out if they so choose? And I was just thinking, in your cost analysis, I don't recall you citing the cost of a single citation if you're found to be in violation of the standard, which is over $13,000 per violation.
Correct. I mentioned it, but did not put it in black and white here. But absolutely, it's over 13 grand per instance for sure.
So I'm not aware of any opt out. Are you?
There is no opt out for companies, right? But again, there are criteria in which your workforce may not be subject to the ETS that we mentioned earlier. If your workforce is 100% distributed, meaning that they're not coming into the workplace and they are remote workers, they are exempt. If they don't have instances in which they're working indoors, meaning that they work outdoors 100%, they are exempt. So these are criteria that should be applied for sure to your workforce to make sure you're not doing more than you need to be compliant in those circumstances.
Follow-up question to the citation. How do you define the application of a violation? Is it every single person who you don't comply for on behalf of every employee, or like, is it defined more specifically?
I have not seen, I mean, so there is a section in the Federal Register for the ETS, excuse me, that speaks to the general duty clause as inadequate to meet the current crisis, right? So we can't use the general duty clause as a litmus for how the violation is defined. Each violation is defined, but from our kind of anecdotal digestion of the ETS, it is per worker that may be subject to a instance of violation. So again, you have one worker that's not compliant with his or her testing and they're unvaccinated, that may be considered one instance and one instance of a violation, and then you multiply that by the number of folk who are not compliant, which is why and from that interpretation, we took that from the requirement to hold these records on demand for inspection by OSHA if they come and knocking, right? You have to have everyone who's been vaccinated documented. You have to have everyone who's been testing documented and keep serially the records thereof. And that's why we kind of derive the notion that each time there's a non-compliance, that's an instance. Now, we hope there will be further clarification on that, but as of right now, that's our understanding.
Okay, couple more questions we have time for. We're currently conducting weekly testing for all employees regardless of their vaccination status. These tests are being conducted on site. Some concerns that have been brought to HR is when the new ETS is set to begin, non-vaccinated employees are afraid of retaliation, are having a target put on their back from other fully vaccinated coworkers. What's your view on this situation?
Wait, can you repeat that one more time? I want to make sure I'm understanding that correctly.
The upshot of it is once the ETS goes into effect, and non-vaccinated employees are required to test, that vaccinated employees may not be required any longer. And it kind of puts a target on their back because everyone will know they're not vaccinated. So it's like a scarlet letter kind of question. So they want to know your opinion about that.
Sure. So, I mean, we've seen a number of that scenario, kind of different instances of that scenario play out, right? And by that, I mean, we've seen corporations that number 120,000 employees strong take the tactic of, we'll put a sticker on your badge if you get vaccinated, which delineates, again, I kind of jocularly refer to that as a Dr. Seuss reference, right? Instances of having stars on your belly or not, right? But it's true. We know companies have taken that approach. And so far, we haven't seen a tremendous backlash in aggregate from that approach, right? And so when we're talking about testing, it may not necessarily be the case, particularly if you're doing home testing strategies that we see several, well, probably half the companies taking advantage of. A scenario in which individuals in the workplace actually know who is and who's not vaccinated, because you're simply testing at home and providing the results back to the employer with no publicly facing labeling of that individual. So, so far, we haven't seen a huge backlash on either approach.
Okay, and then Jeff just pointed out that non-vaccinated employees will be required to wear a mask, but vaccinated employees won't necessarily be required to wear a mask, depending on the setting.
That's absolutely true. That's part of the ETS, and that will obviously delineate who's vaccinated and who's not. But again, it begs the question, how do you identify who's vaccinated and who's not? Do you have to have some type of badge designation so that your boots on the ground enforcers will point out, Susie, you're not vaccinated, where's your mask, right? So you see the difficulty in trying to delineate without some type of designation who is and who's not vaccinated. It will be a problem. There is no easy answer to that question, for sure.
Oh, we have time for one more question and maybe two. Might a signed self-attestation from the employee regarding a negative test result meet the requirement for if the test was performed at home?
In terms of proctored and meeting the criteria for proctored, perhaps not, right? We know that attestations have been used prior to the ETS so that it holds the employee at a higher standard or a higher requirement and is grounds for dismissal. We've seen that happen if it is found to be falsified. But in terms of meeting the definition of proctored by the ETS, an attestation may not cut it, unfortunately.
Okay. Oh boy, we're getting all sorts of questions now at the last minute. So I want to remind folks, those questions that don't get answered, we'll answer them in writing and post them on our COVID-19 webpage, which you can find at workcare.com. Do you have any sense on which employers are paying for testing as opposed to those that are requiring employees to pay for testing? Or is it too soon for us to really have a solid number?
Sure. So that actually will be one of the polls that we'd like to take as this progresses with the populations that we serve, because there is definitely a strategy to it in regards to making your organization more or less competitive in the market that you're in, right? And I've had this conversation several times with not just direct employers, but organizations that represent multiple employers in terms of interest or industry groups. And by what I've gleaned thus far is that the majority of employers are not passing on the cost to employees because the job market at this point in time is tremendously hot, right? Turnover is higher than it's been in past years, and being competitive in the marketplace is obviously a competitive advantage for our employers, and creating the scenario in which you now allow your competitor to gain an advantage from an employment standpoint by saying, hey, come to us, we won't bill you or charge you or pass on the cost for your compliance testing, becomes somewhat attractive, right? And so we want to make sure that that is a consideration for our employers. We know that it is, but right now we've anecdotally seen the majority of employers not pass on the cost.
Okay, we're out of time, but there's one question about the home testing strategy. Just to clarify, if it's a remote worker, how is it really practically applied to do an observation of someone's working remotely and doing home testing? What
Sure.
kind of technology is there available to facilitate that?
Sure. So there are digital platforms, many vendors, including WorkCare, have in place where we're able to, on a mobile device, have a FaceTime-like encounter, and directly observe that individual both collecting as well as testing themselves in regards to getting the results from a rapid test. If it's a PCR test, obviously, then it's the collection only that's being observed. And once they ship that off to the lab, we get the results and report it back. So there are a number of vendors with technology as such to render that type of service at a price point that's not prohibitive for everyone, right? It may be for some, but we know that there are employers that are moving in that direction.
Okay, then Lori just commented, why take off your mask if you're vaccinated? You could still get a breakthrough infection, but that's more a comment than a question. So
Well,
we'll end.
it also begs the question, right? I mean, this is, you guys don't see me get too cynical too often, but if we were all wearing masks in the workplace, we wouldn't be talking about an ETS, right? Let's look back at the airline industry. There are no mandates to get on a plane. And the rates of transmission is non-existent. Why? Because everyone is still masking up. And I know we want to get out of wearing masks, but which is worse, the lesser of the evils, wearing a mask or having the mandate in place and all the repercussions thereof, as you've seen, the $3 billion in costs. So just one thing to point out in terms of considerations as we as a society move forward through this pandemic, and one that I'm sure won't be answered anytime soon. So with that, thanks everybody for joining this special edition of our webinar. And I'll let you wrap it up here, Karen.
Thanks so much, Dr. Harris, and to all of you who joined us. Reminder, we'll be back on December 1st for our regular monthly webinar. And if we schedule something in between, we'll be sure to let you know through our constant contact messaging and other notices. So thanks again, be safe, and we'll see you back here next month.
Thanks, everyone. And as always, be safe and God bless.